Hello, everyone. My name is Kian Shashari, and I will be presenting this skill a month on malignant hyperthermia. So what exactly is malignant hyperthermia? Malignant hyperthermia, it's essentially an inherited pharmacogenetic disorder of skeletal muscle. It's triggered by exposure to certain anesthetics, which essentially leads to an uncontrolled calcium release, causing massive muscle contraction, and is a pretty dangerous metabolic crisis. So, what exactly happens during malignant hyperthermia? As I just mentioned, there's this excessive muscle contractions that's caused by calcium being released excessively throughout the muscles. Muscles often become very active and stiff, which then causes a rapid rise in our body's temperature as we're producing heat very quickly, which then leads to acidosis, leading to tachycardia, tachypnea, dark urine, sweating, confusion, blood acidosis, and seizures as well. All right, a little bit on the pathophys overview. The calcium overload drives acidosis, hyperkalemia, and rhabdo. This all contributes to cardiac arrhythmias, multi-organ dysfunction. As a reminder, rhabdo is the condition where muscle cells break down so badly that they release their contents into the bloodstream, which can hurt your kidneys and is usually treated with lots of IV fluids to flush out the kidneys. As you can see in this next slide here, some of the common triggers for malignant hyperthermia include succinylcholine, which is a depolarizing neuromuscular blocker, also known as a commonly given paralytic medication that we use in some of our RSI situations. Inhaled anesthetics are also a pretty common trigger of MH, and any sort of pretty severe stress, heat, and strenuous exercise can cause MH. And although MH is typically seen in the OR setting, we do have to remember that it is something that we can see in the emergency department whenever we're doing any sort of intubations, as previously mentioned, like RSIs, and when we're using sucks. Our patients, we need to know that our patients are susceptible to malignant hyperthermia. Some things to know in terms of risk factors for our patients, things to look out for. So a family history of MH or unexplained anesthesia kind of complications put them at a risk for developing MH. Any sort of history of muscle rigidity after any sort of anesthesia or rhabdo after anesthesia puts them at risk, and a known RYR1 mutation. It's important to, if we have the time and we're able to, it's important to ask our patients and or our family members that are with the patients about any sort of possible anesthesia reactions that the patient or family has had in the past before any procedure that may require a volatile agent or succinylcholine. All right, so early recognition of MH. So as previously mentioned, things that we're supposed to be looking out for would be tachycardia, muscle rigidity, muscle spasm, a really rapid increase in temperature, dark urine. We're also looking out for a rapid increase in our end-tidal CO2. Hopefully, when we are doing a procedure that may put our patients at risk for MH, hopefully we have a temp sensing Foley, so we are able to see this rapid rise in temperature. We're having good eyes on our patient, seeing if there's any sort of muscle rigidity or spasms. If they do have the Foley in, we're seeing if they're having any darker urine. Early detection really does save lives in this situation. So it's important that we are aware of things to look out for. In terms of diagnostic findings, we are going to be taking a look at our blood gases. Hyperkalemia and hypercalcemia are they're going to be findings that we see with our patients with MH. Any sort of elevated CK and myoglobin levels. And then, as previously mentioned, the myoglobin urea, which is that dark, kind of amber-colored, tea-colored urine, and rhabdo. Diagnosis is primarily clinical, but the labs that we do get from our patients confirm MH and are kind of what we use to monitor the severity of the MH being seen by our patients. So it's always important to watch for worsening acidosis and any sort of electrolyte derangements. All right, so we're observing MH in our patient now. What are the emergency management and things that we need to do? So immediately we need to stop all triggering agents. We need to, per UCSD policy, activate a code malignant hyperthermia. So this would be dialed up as, a standard 6111 call out. We would be calling out for a code malignant hyperthermia, along with our, exact location of where the patient's at, and a response team will come, outside of the ED setting. Reason I'm telling you guys all of this also is because, as EDIP nurses, some of us on the EDIP side, it's important to know that we need to be calling out this number, stating our exact locations. And when you do this, a response team consisting of RNs, pharmacists, and anesthesiologists will come by with a cart as well. So pharmacy will come by with an MH cart. I'll show you in the slides to come what that cart comes with, but the main thing that we need to be concerned for and to look out for is the dantrolene medication, which is our reversal agent. It's important that we are going to be administering the dantrolene at 2.5 milligrams per kilogram via IV. We can repeat as needed for a maximum of 10 milligrams per kilogram. Administer dantrolene fast, assign clear roles. One person mixes dantrolene, one manages airway, one's cooling the patient, documenting, and all of that kind of leads to my next slide. So we have our malignant hyperthermia cart checklist. So in this MH cart that I previously mentioned, there will be this checklist that you see on the right hand of your screen. It has a top section for all of the refrigerated IV fluids. It should come with a central line kit and then medications that would be useful in these sorts of situations. As previously mentioned, the dantrolene medication will be in there. You'll also have D50, some sodium bicarb, lidocaine, furosemide, heparin. You can see it all on your screen. So here is a kind of, step-by-step sheet that the actual dantrolene sodium Ryanodex website has, has a page on their website. And it kind of goes over how you go about administering the medication. It's also found in UCSD's policy. It's 803.3. But something to keep in mind when we have these... something to keep in mind is that we do have these malignant hyperthermia starter kits. I'm guessing they're in the A side Pyxis. So this starter kit contains enough dantrolene to provide the initial bolus, which I mentioned, which is that 2.5 milligrams per kilogram administration, in order to buy us some time for the malignant hyperthermia cart to come and need to be wheeled by to the actual location of the code. The malignant hyperthermia starter medication kit includes 2 vials of the Ryanodex, which is the dantrolene, 2 vials of 10 ml sterile water, 2 5 ml syringes, 2 needles, and 1 dosing card. So we'll go step by step step number 1. So you're going to add 5 mLs sterile water for the injection to each 250 milligram vial of Ryanodex. Step 2, you're going to shake the vial until the medication is mixed thoroughly. Shouldn't take more than 10 seconds. And the suspension should be a uniform orange color. Step 3, we're going to draw out the reconstituted suspension into the syringe. And you can see the concentration dosing on the bottom there. Step number 4, we are going to administer via IV push. And as you can see here, you kind of have the dosage chart for the dantrolene. All right. So along with the medication administration, some supportive management, we want to actively be cooling our patient with IV fluids, ice packs to the groin, axilla. We can use our Arctic Sun. We want to correct the acidosis with sodium bicarb. We're going to also manage the hyperkalemia. So we're going to be, doing our Hyper-K protocol, insulin plus dextrose. We're going to be treating the arrhythmias with medications, but it's important to know that we're going to be avoiding calcium channel blockers, and any other supportive measurement to prevent secondary complications would be considered as supportive management. Really important thing, cooling should stop when the patient reaches 38 degrees Celsius to prevent overshoot hypothermia as well. So post-crisis care here now. So we're going to continue the dantrolene 1 milligram per kilogram IV every 4 to 6 hours, or 0.25 milligrams per kilogram an hour by continuous infusion for 24 hours plus. Relapses may occur within 24 hours, so continued dantrolene and close monitoring of our patient is essential. We also want to let you guys know that 25% of MH cases do end up having a relapse. So it's important to keep a close eye on the patient even after we've, administered the medication, performed our supportive management as well. All right, so a little bit of a summary of malignant hyperthermia. It's important to recognize the MH early. So as a reminder, muscle rigidity, the tachycardia, the darker urine, and tidal CO2 rise. It's important to stop the triggers and give dantrolene immediately. It's important to provide supportive care, which includes correcting acidosis, managing our hyperkalemia, cooling off our patient, and it's important to maintain the malignant hyperthermia readiness and have a strong team coordination throughout the entire process. Lastly, here is a MH crisis checklist that I found off of the UCSD website. This one here is La Jolla specific. There is also a Hillcrest one as well, and there should be an East Campus one online as well. But if you ever need to check the UCSD 803.3 policy again, please refer to the link that I have provided with you guys here. Thank you guys, and thanks for listening.